Good morning, everyone. I'm going to share our experience with one of the diffuse large B-cell lymphoma patient which we treated with metronomic chemotherapy. So, the patient is a 74 female. She is known diabetic and hypertension on regular treatment. She had history of upper GI bleed with aspirin, and she had undergone hip replacement for her fracture neck femur some time back. But otherwise, she was in good PS, and she was diagnosed to have DLBL stage 4 AEX. She had multiple subcutaneous deposits and kind of extensive disease. The baseline IPI was not available for this patient. In view of her age, she received rituximab combined with COP. We avoided anthracycline in view of her age for this patient. And after 4 cycles, she achieved a complete metabolic remission on PET scan, and her tolerance was good. There was no admissions, no infections, etc. She completed her 4 cycles and she was put on follow-up. Unfortunately, at 3 months from treatment completion, she came back with florid disease with similar thing. This time her PS has dipped, otherwise she was medically well controlled. She had good family support. Her son was a software engineer, and we discussed the prognosis of this patient with family. The obvious question from family was, what is her expected life, what are problems she is going to go through if she has progression, and how we can minimize this problem. So after knowing that her life is in months after a relapse aggressive lymphoma, son was keen to start some treatment. The options which we could offer were single agent rituximab, steroids alone, some low dose chemotherapy, and family was very clear they don't want any toxicities, so that was their prime goal. So control the disease but without any problem to her. So she was unfit for aggressive and salvage chemotherapy and transplant, so that was not an option at all for, and we started her on metronomic chemotherapy. So we changed our protocol a bit here. We used endoxan 50 mg OD and etoposide 50 mg OD for 2 weeks followed by 7 days break. We avoided celecoxib in view of her history of upper GI bleed and steroids for her sugars, and she surprisingly did well. Her tolerance was very good, but on routine CBC she was found to have developing neutropenia, so the dose were curtailed by 25% even if she did not have any febrile neutropenia, because at the back of mind we never wanted her to come to hospital and have a serious infection. Clinically she was responding, and so as to document the response we did a 4-month PET scan, and that showed a complete metabolic remission. Now the next question was how long to continue, and obviously when to stop. So after thinking that she has relapsed immediately after stoppage of RCOP, a pretty aggressive chemotherapy, we continued her for a year, and after that we stopped her. So this lady, she continues to do well. Her tolerance is to chemotherapy was very well. She had only one infection, that was non-neutropenic skin infection. It was managed on OPD basis, and she did not require any hospitalization. So at 1 year 9 months from completion of her oral chemotherapy, she is doing fine. We have not done any imaging further, but she looks to be in the remission. So this seems to be a rare case where patient has achieved a longer remission duration with metronomic chemotherapy as opposed to a rituximab COP, which would be a standard of care for this age, this thing. And that is why I thought I will share this case with you. This brings out many questions. What is the best regimen for metronomic chemotherapy in lymphoma? What is the best subtype to give metronomic chemotherapy, means out of these different subtypes of lymphomas, aggressive versus indolent, and which is likely to benefit more? What should be the duration? It should be like until progression or toxicity, or we should stop somewhere after achieving the goal of palliation? Should we include targeted therapies, because there is no data in this situation, but most of our patients would be receiving rituximab and they would be relapsing after that. So we really don't know what would be the role of rituximab. Are there any predictors of response? Because if we want to do such an intervention in such heavily pre-treated patient, we need to be very sure that she is going to benefit. So can we predict something about that? And what's our goal? Can we cure some of this patient by giving metronomic chemotherapy? Because this looks a functional cure as far as this individual patient is concerned. Just a bit of review of literature. So these are multiple retrospective and prospective studies, and this study shows that there is a very good response rate with metronomic chemotherapy in lymphoma. This is much higher than many of the solid tumors. So probably this is one of the subtypes of malignancies where metronomic chemotherapy you can expect some kind of responses. The commonly used, the backbone of all this chemotherapy is cyclophosphamide. We have been hearing this for last 2 days. It is combined with prednisolone. The very famous regimen Pepsi is one of the regimen used, and that has been reported at multiple centers, and that's one of the popular regimen. Coming to next point, how do we tailor our treatment? So I took this example because Hodgkin's disease, this is a disease where tumor cells are very less. Most of the tumor burden is of the surrounding inflammatory or reactive cells, and there is a chance of controlling these cells by biomodulation. So mTOR inhibition, PFAR inhibition, and COX inhibition has been tried besides giving them chemotherapy, and this has a promise to overcome the chemo resistance in this patient. So one of the very elegant study where this investigators, they used mTOR inhibitor, alkylator oral triosulfan, COX inhibitor etocoxib, steroids, and PPAR inhibitor pioglitazone, and they showed in their series of 3 patients that PET negativity can be achieved very early with this kind of combination with lethal toxicity. They went ahead, they did CRP of all these patients, and they showed how CRP behaves with these patients when we treat them with chemotherapy and when we treat them with metronomic chemotherapy. So the very interesting thing is CRP doesn't come down with high dose chemotherapy. So this is a DHAP and CRP is up after DHAP, then beam, this is there, then this is after progression. But when the patient was started on metronomic chemotherapy, the CRPs tend to be low. So this proves that this combination chemotherapy controls the inflammation besides attacking the tumor cells, and a different mechanism of action is highlighted by this model. Coming to second example, lenalidomide with endoxanine Hodgkin's lymphoma, because it's immunomodulatory drug and it has shown very good response rate, benefit rate, etc. This is one of the options which can be considered for this Hodgkin's disease lymphoma. Second example which I have taken is ALCL, very interesting data. So vinblastine is known to have activity in ALCL for long. This drug has been reported by, I have brought one reference, this investigator reported that few of the patients were in the relapse refractory setting were controlled with vinblastine for up to 7 years. So that means they are practically cured of the disease. But surprisingly, a ALCL 99 study, a randomized controlled trial in US done after initial promising result, turned out to be negative. So vinblastine in induction and maintenance has failed, and we don't understand the reason. No investigator would jump on a phase 3 randomized trial unless and until he is expecting a positive results, and we need to find out the results, what are this. And many times we see subgroup analysis or post hoc analysis being done to salvage a failed trial, but this trial there is a very good way of salvaging. This is a correspondence by independent writers to this slide, and they try to explain what happens. So they feel that probably the duration of vinblastine use was different, it was used lesser duration, then frequency was not that frequent like a metronomic chemotherapy kind of schedule. Then they feel that a hit hard approach probably eradicate all the cells, so there is no chronic antigen stimulation, so that immune control over tumor is lost. And this authors trying to point out that probably the vinblastine usage in this trial was not properly, and there is a scope to improve this. So I just brought to highlight that how metronomic therapy could put answers to some of our questions in the conventional chemotherapy. Vinblastine has been shown to activate. This is not actually a metronomic schedule, but we use vinblastine at our hospital as a part of upfront treatment of anaplastic large cell lymphoma. And here we also noted that there is a very high PET negativity with vinblastine. The vinblastine is given weekly, so probably the metronomic scheduling is helping our patient, and this is well tolerated at our center. Just to share our experience with vinblastine. Sir, another interesting thing is mantle cell lymphoma, where people try to, this tumor is supposed to be very pro-angiogenic. So people try to curb this angiogenesis by adding thalidomide and rituximab, and what they have seen is there are good responses with this Pepsi when it is combined with rituximab and thalidomide, but they showed that VEGF level and circulating endothelial cells come down with this chemotherapy. So probably there are ways to target the individual disease subtype by designing a specific protocol for that disease, and you can see the responses 82% and 73%. So this is one of the very good response rate in metronomic chemotherapy results as far as I know. So I can conclude that there is a significant proportion of lymphoma patient who would be responding. These responses would be durable. Only thing is we need to identify what are these subtypes, what is the best regimen for a subtype of the disease, and we always have to keep an eye on patient's tolerance, and we have to modify the our chemotherapy or plan accordingly so that we don't end up in giving toxicity to our patient. Thank you.